Welcome to HealthScreenTV. Our HealthScreenTV channel is dedicated to promoting scientific and evidence-based information. We don't interview influencers on Instagram. It's all about real medicine, real science, and real experts. And what a panel of experts we have with us today. The topic for today's discussion is women's health. It's all about starting from fertility to menopause and screening for ovarian cancer. I'd like to introduce the panel and welcome everyone. We have with us Dr. Sarah White, who of course is the Chief Executive Officer of Jean Hales. Jean Hales is the peak women's health organisation dedicated to promoting and improving women's health. And Sarah, of course, also has a PhD in paediatric genetics. Welcome to the program. Dr. Sonia Davison is a PhD and an endocrinologist and research fellow also at the Monash University. Sonia is also a staff member at Jean Hales, and of course is the past president of the Australasian Menopause Society. Welcome.
Thank you.
Dr. Michaela Sorensen, who's a prominent GP who is based in Sydney with particular interest in women's health and is actually a regular presenter on the morning show on Channel 7. And of course is now our medical specialist at our HealthScreen facility in Sydney. And finally, Associate Professor Alex Polikoff, who is a prominent obstetrician and gynecologist who is on staff at the Royal Women's Hospital in Melbourne. Alex is also medical director of Genea Fertility and holds 4 separate master's degrees, including medical law and medical ethics. Very impressive, Alex.
Thank you. It's a pleasure to be here.
It's a pretty good job.
So what an impressive panel. I think we have enough brain power to solve all the women's health problems today. So let's start. So I prepared a list of questions. So I think my first question is really to the panel is when we talk about women's health in 2025, it means different things to different people. Can we maybe just go around the table and tell us what do we mean by that? What does that mean, women's health in 2025? Maybe we'll start with Dr. Sarah White.
Well, David, I think for me in today's landscape, it really means thinking about women's health beyond the bikini line. We now know there are sex and gender sensitive issues to women's health. And so that means our brains are different, our pain is different, our hearts are different. And I think we're moving beyond that sense that women's health is just restricted to hormones and just restricted to our sexual and reproductive health.
Michaela.
Yeah, look, absolutely, Sarah. I think you articulated that beautifully. I think when we've talked about women's health in the past, we've talked about fertility, periods, menopause. At best, if we got to menopause, often that was ignored. But we know now it's a whole body, and it's also beyond the physical health. It's also looking at the entire social context in which that occurs as well, because we know that has huge impacts on women's health and health issues impact women in a social context. So it goes both ways. So I think when we treat women, look at women's health, we need to look at that whole psychosocial model.
Sonia.
To me, it's about what you referred to before, and that's basing our thoughts, our beliefs, and our messages on science and evidence. Because I think in this era and at this time in our lives, we are surrounded by a so-called lot of experts who, for whatever reason, are putting a lot of information out there. So I think women's health, we want to keep women healthy in the right, correct, safe way and make sure the messages are scientific and evidence-based and not because you've been an expert for 5 minutes.
Alex.
I think I agree with the previous speakers. I think Sarah brought up a very important point, and that is that women's health is part of the societal health, and there are influences going back and forth around that. I think Michaela said it right when it's not just the women, it's their place in society and how health affects them and how the society affects them and how women's health affects the society. For example, in fertility space, we have a lot of sort of issues that arise not because of women's changing their lifestyle, but because of the society is changing. And I think that's very important. And of course, Sonia is absolutely right. I mean, there are influencers and experts, so to speak, who provide, terrible, unscientific advice. And we as doctors face that every day, trying to convince people not to do silly things and, stick with science, stick with evidence. So I think all of those points are very, very important.
Yeah, I totally agree. Sarah, I guess my first sort of specific question is to you. Jean Hales is leading the conversation nationally in women's health. What do you see are the main gaps in women's health issues and management at the moment?
Well, I think that could be a whole other podcast, David, because I think the public health gaps are many and varied, particularly as we think about the social, cultural context and the sex and gender specific medicine. But if I want to focus perhaps on those health gaps related to hormones at every age, two of the key things we've been looking at recently this really significant and growing problem when it comes to young women who are holding unfounded fears about the side effects of hormonal contraception. And then for midlife women, we know there's a big gap between the proportion of women affected by menopause symptoms, badly affected by menopause symptoms, and those who are using menopause hormone therapy. And it comes back to the point that Sonia made. A lot of these unfounded fears are really coming from misinformation and from it's social media for the younger women, social media for midlife women, but also a hangover of irresponsible mainstream media reporting. So they're two big gaps if we just think about the health and hormones over the lifespan.
Thank you. I've got a question for Michaela. Michaela, what sort of aspects of health as a general practitioner do women feel, in your experience, they don't feel that they'd be taken seriously by, obviously not by you, but other general practitioners?
Oh, this is such a complex question with so many layers because I actually genuinely think it's all aspects of health. Women come in wanting to talk about, they're worried about their heart health, they get chest pain, they get short of breath, and they get told, oh, you're anxious or stressed, or just take a holiday. Or they get worried about their cycles and their pelvic pain. They get told, oh, no, it's just hormones changing, you're fine, it's just life, you just have to put up with it. So I think it's all aspects, physical, psychological, hormonal, non-hormonal. I think so many women have experienced, unfortunately, that they've either been dismissed or ignored or been made feel almost somewhat histrionic by coming in to present their concerns. And I think there's a few reasons for that. One, whether we like to admit it or not as doctors, is a lack of awareness of women's health, and we weren't trained well in it. I know when I went through medical school, we did a month on ischemic heart disease, yet we did one 1 hour lecture on menopause. So there's just such a huge disconnect there and a lack of awareness and understanding. Also looking at the structure of primary care, a 15-minute appointment is nowhere near enough to touch the sides of one simple issue, let alone an undiagnosed, undifferentiated health concern. And also, on the flip side, at the risk of being somewhat controversial with this, as women, we don't help ourselves either. And this is probably a byproduct of society and the way we're trained. But if I get, and with due respect to the gentleman sitting here across from me, but men come in, they sit in front of me and they go, this is what's wrong with me, this is what I want, this is what I need. Okay, let's talk through it, let's break it down. Whereas women often, more often than not, come in and say, look, it's probably nothing, I'm probably just stressed, I'm probably just overreacting, but, and when you lead in with that, it sort of doesn't do yourself any favors. It kind of, particularly if people don't have that interest or that focus or the time to explore things further, they often agree and say, yeah, okay, maybe it is just stress. So I think as women, we need to advocate for ourselves better and feel more confident in actually articulating what's worrying us.
Thank you. Sonia, I have a lot of questions for you, but I'm just going to keep you on ice for the moment. I've just got a quick question for Alex, perhaps. Are there any aspects of gynecological health that women misunderstand that sort of stand out to you, Alex?
Well, I think I would have to agree with Sarah, and that is a lot of women are concerned about possible long-term side effects of things like contraception and HRT. And I literally spend a lot of time in my practice trying to convince people that, if you have a condition that is hormone imbalance related, so to speak, uh, there are very limited options to treat it without some sort of hormonal manipulation. And, there are certain risks, of course, but the benefit would probably outweigh those. I think that is important. There is a lot of fear out there about unnatural therapies. People are, leaning towards, we want it to be natural. We want everything to be natural. But, it's not always possible. For example, treating things like PCOS, it's tricky. I mean, there are lifestyle changes, of course, that we always recommend, which are difficult to implement. And, the mainstream of therapies is really some sort of hormonal manipulation. And the fear of that is a major limiting factor, I feel.
Right. I did a bit of a survey in terms of what did I guess the general public and patients wanted to hear. And there are two items that stood out, and we're going to talk about that. One was endometriosis, and the other one was menopause and management of those conditions. But I wanted perhaps to start with a little bit about reproductive health and longevity, because they're sort of all intertwined. So in terms of fertility, Alex, at what age should women be starting to think proactively about their fertility? And of course, women are now having babies later in life. Should we be starting and freezing, not we, but I mean women, should women start and freeze their eggs? Because there's a lot of that controversial issues going on as well.
Yeah.
What are your thoughts on all this?
It's a very controversial area. I mean, we know from all the research that we've done and many other groups that the quality and the number of eggs usually starts to drop exponentially at about the age of 35. But that's on average. It's not everyone. I mean, there are some women who have reduced fertility starting in the early 20s. And so it's a bit of a balance, because we know that women who freeze their eggs when they're very young are very unlikely to actually come back and use them, because they have plenty of time to meet someone and have a family. While if women come in a bit later, for example at the age of 40, the quality of frozen eggs would be not fantastic. They probably wouldn't get a baby out of that. So there is some sort of a golden age where we think, women should think about these things. And all the research points towards perhaps somewhere around early 30s, mid 30s would be the best time. I think there are tests now available to look at fertility and ovarian reserve. Unfortunately, they don't have long-term predictive value. So I'm talking about AMH, and you measure it today and it's fine, but you have no idea what it will be in a year or two. So it's reassuring to have for now, but it doesn't mean that your fertility will be okay for the next 5 years. That's one important point to make. And second point is that, look, it's very difficult to give advice as to when egg freezing is appropriate. I think there are many factors that go into that decision. One of the major barriers, of course, is the cost, because it's not subsidized by Medicare. It ranges between $4,000 and $6,000-$7,000 for a round of egg freezing. We do it, and it's available for almost free for women who are facing chemotherapy with the new cancer diagnosis. That service is available through public and private clinics almost for free. But for what we call elective or non-medical egg freezing, there is still a significant cost associated with that. I would say somewhere early 30s, mid 30s would be an appropriate time to think about it. But I think there is also a need for more education of younger women to bring across the idea that IVF, it works, but it's not really designed for age-related fertility decline. That's not what it's for. It doesn't help that.
Okay. Thank you, Alice. I've got another question to you first, because I want to talk about endometriosis. And as my understanding is, in Australia, 1 in 9 women is diagnosed with endometriosis. There's usually 7 to 10 years delay in terms of diagnosis. And in patients with infertility, nearly 50% have endometriosis. Why is there such a delay in diagnosing this, obviously very important condition?
Well, there is no doubt that endometriosis is extremely common. We don't know the true prevalence, mainly because the only way to diagnose it with 100% certainty is to have a biopsy from peritoneal cavity, which requires a laparoscopy. And obviously it's a major invasive procedure which you wouldn't want to undergo just, for no reason at all. And when people talk about delaying diagnosis, unless and until a woman has a laparoscopy and has a visual confirmation of endometriosis, you can't really reliably say that that's what it is. Severe endometriosis can often be seen on ultrasound, CTs, and MRI, but mild to moderate endometriosis, where the plaques are flat, they're not three-dimensional, usually is not seen on imaging. And so women present repeatedly with pelvic pain at various points of the menstrual cycle, and often doctors don't dismiss it. They just say, look, it could be endometriosis. We can't say for sure. Why don't you try being on the pill? Or, somehow manipulate your hormones so there are no fluctuations, and then your pain should go away. The main problem with diagnosing endometriosis is that requirement for laparoscopy. You need a biopsy diagnosis. And in fact, one of the newer medications called Ryeqo, which is fantastic at treating endometriotic pain. I give it out a lot. I prescribe it a lot, and it's only been on the market for a little while. But one of the conditions that is attached to PBS listing is visual confirmation of endometriosis. So unless you have that, it can't be prescribed on PBS.
Okay. Thank you. Question for Michaela in relation to endometriosis. Because the symptoms of endometriosis are fairly non-specific, how do you balance between diagnosis and not sort of over-investigating? Because that's a fine line, isn't it, with non-specific symptoms?
It's such a fine line. It is such a fine line. And I think what you often find is, because a lot of the symptoms are, as you said, non-specific, and a lot of them are beyond sort of pelvic pain. A lot of the things that I see in general practice, one of the most common symptoms are women that have been told for the last 12 years that they've got IBS. And so they try and manage this IBS, and it never gets better. And they go and have endoscopies and colonoscopies and all of that, abdominal ultrasound, CT scans, and nothing shows up. And it's not until, say, many years later that someone sort of thinks, oh, well, maybe it's not your gut, maybe it's actually endo. And that's, so trying to, I guess, have it in the thought process so that women aren't going through unnecessary investigations, thinking about it first, so you're not sending them for a range of other tests. But I think the other thing is having those open and frank conversations, and circling back to something that we spoke about earlier with social media. I see a lot of young women in my clinic, and it's that balance, because as we mentioned, a lot of women are wanting to go natural, and we have the conversation about, well, even though it's hard to diagnose endometriosis, we might do an ultrasound and it's probably going to be normal, but that doesn't mean you don't have it. Why don't we try the pill? And the answer is always, oh no, but I don't want anything hormonal, or that's just a band-aid, or I just want a laparoscopy, because I think it's all over Instagram and TikTok now that you need a laparoscopy, and it's almost seen as just a quick, simple thing. Oh, it's just a keyhole surgery. It's fine. That's what I need. And so trying to talk them down from that and explain, well, actually, it's a major surgery. It's anesthetic. There's risks associated with it. And there's also the chance that if it's removed, it can grow back. And, we've got to have a long-term plan. And that plan has to be not only pain relief, but also preventing, fertility complications and things as well. So look, I haven't really answered your question, I know, because it's a difficult balance. And I don't think anyone has a definite answer to that. It's treating the individual in front of you. There will be some that will be inclined to push for further investigations, and then there'll be other patients that sort of want to go the path of least resistance. So it's just managing the individual in front of you and making sure that you're actually hearing and valuing and taking into consideration what their concerns, what their symptoms are, and developing an individual approach.
Yeah, it's definitely is a very difficult area to navigate. I've got a question for the panel now in that respect. Perhaps it's a leading question. What do you think about, and is it necessary to have multidisciplinary management of endometriosis because it's such a complex condition?
Well, it depends, is my answer. Because some women are quite well managed on the pill. And, you can make a symptomatic diagnosis, and if they don't want to achieve a pregnancy and the pill is the best option for reducing bleeding, reducing pain, it could be a very good GP. It could even be a not so good GP who manages them. But the more complex cases, I think, do need the team input. But of course, that's very hard because a lot of us are very busy, and specialists have closed their books. And, it is hard to gain access, especially in rural areas, to specialists too. So it's easy to say that term, multidisciplinary. Well, it's not actually easy. It's harder to spell, but it's harder to get access to, and it's not always needed.
Thank you. Now, Sonia, all the questions that are coming up are going to be for you, because we're going to talk now about, in this sort of later half of the meeting, about the menopause and hormones. And so my first question to you is this. I think even in medical circles, menopause is still not sort of widely discussed. Is this still a bit of a taboo at this point in time? And, why is this?
No, it's not. Menopause is hot.
Yep.
Endometriosis is hot. You are talking about two very hot topics in medicine and women's health. So it used to be a taboo. Women did not want to associate with menopause. Jean Hales tried to find a menopause ambassador some years ago, and all of the starlets and actresses and celebrities said, "Do not associate me with menopause. I will become invisible. I will become uncool." So it was a really... But now you'll open your magazine at the hairdresser at Vogue and see Michelle Obama, Naomi Watts talking about menopause. So, David, this is a really good time to do this podcast because menopause, endometriosis are really hot topics. And unfortunately, some other topics which are really important might have got put to the back burner, such as PMS, for example, polycystic ovary syndrome. So as you know, in medicine, things come in waves, but I'm glad you're focusing on menopause because it is literally and figuratively hot.
Sonia, thank you very much. Can you maybe walk us through pros and cons of hormone therapy for menopause?
Well, there's a beautiful statement which the expert bodies and expert opinions and all of the menopause societies around the world have sort of come across or figured out, and that is the benefits of hormone therapy for healthy women around the time of menopause far outweigh the small risks associated with its use. So I think I often just spell that out very clearly to women. It is a very powerful statement, well thought out, considered and evidence-based. We know that hormone therapy will help symptoms. We know that it will help bones and heart. There is actually, the pendulum has swung the other way. A lot of women were very reluctant to take hormone therapy after the release of that big WHI study in 2002, and hormone therapy use literally just dropped to the ground. But it's actually probably dangerously gone the other way, with a lot of people out there saying that hormone therapy is good for everything, including putting estrogen on your skin and all these messages which are quite wrong and not evidence-based. So women are really just seeking hormone therapy in great numbers, and that's why we've got a lot of hormone therapy shortages. So it's become a very, very difficult area, and to get those important messages out. Jean Hales are doing a great job doing it. Michaela and I are doing our damnedest to do it. but also the Australasian Menopause Society have got some great information if your listeners need further advice.
Thank you. Sonia, I wanted also to touch on perimenopause, which what is perimenopause and what are the symptoms and how can we manage perimenopause?
I call perimenopause a beast for some women. It's a very difficult time. Our poor hypothalamus and pituitary are desperately trying to get the ovaries to get eggs to develop and make estrogen. It's programmed to do that from puberty. But unfortunately, it's a bit sad. We're running out of eggs. So sometimes there will be an egg that develops and hormones will be normal. Sometimes there will not be an egg, so estrogen levels are very low. And sometimes the pituitary will try so hard that there's an overshoot and we'll get these enormous estrogen levels. It's a time of fluctuating symptoms from the mid to late 40s typically, but it can last for 11 years before menopause, which has the median age of 51 to 52. So even from the early 40s, women can have symptoms. It is a very, very difficult time to manage. Some will benefit from hormone therapy. Some will need contraception just to really stabilize those hormone levels. And many women will just feel very lost because, again, the fluctuating nature of their symptoms and hormones makes this a very, very difficult time. And perimenopause is a lot harder to manage compared with menopause.
Sonia, what are the common misconceptions that women and also men have about menopause?
Well, there's studies that show that men are very cut and dried about it, actually, if you have a look at it. Men see, I think they're a little bit more cut and dried than women. I think women get lost in the experience and in all the information being bombarded. But the studies have suggested that men see a problem, see the symptoms, see hormone therapy as an option and say, just take it. Whereas women, when they actually go through all of that and they're presented with all the natural, all the other evidence, some of them won't actually opt for hormone therapy even though it would benefit them. So it is a very interesting area when you look at it, and that's why it's so important to get some really good, very clear information. The Gene Health website has that in abundance, and our practitioners are trying to do that. The Australasian Menopause Society also is trying to get that. A Better Health channel is also very good at getting out some good information. It's about pointing people, whether it's doctors, nurses, the community, in the direction of the best evidence-based information and trying to get them away from the other stuff.
Can I just jump in there?
What we're trying to do, of course, as well. What are some of the emerging and sort of research directions that in terms of the menopause that you feel excited about?
Well, there's a lot of information about just the typical hot flush actually being a marker of other processes such as cardiovascular disease. So we do need more information. We need more information about early menopause. We need more information about fertility. If it's research and it's women's health, I'm in. I think Michaela had something to say as well.
I did, Sonia. I'd love to just jump back to what you were saying about women finding it quite difficult to actually make the decision to start HRT. And what I see in primary care for a lot of women, it's not even necessarily concern about side effects of HRT or what it might mean for them physically. It's that acceptance of where they are in life. And for a lot of women, they still see perimenopause and menopause not just as something to fear, but also as a loss of femininity. And for them, going through that stage, that life stage, is really confronting. And what I hear time and time again is, I'm not ready. I'm not ready to be at menopause. I don't feel how I thought I would look and feel when I'm at menopause. They still have these visions of, their grey-haired grandmother with a walking stick going through menopause, but, it's obviously very different now. And so I think that's one of the things that a lot of women really struggle to reconcile. And I spend a lot of time talking through with them about what this actually means and what it translates to physically, but also socially and psychologically as well. So I find that a huge barrier, and that's something that I don't really think enough focuses and emphasis is put on is that social impact on them.
Well, it comes to gendered ageism, doesn't it, Michaela?
Yeah,
And we have
absolutely.
internalized gender ageism, and that, we've done a lot of research, Jean Hales, with our National Women's Health Survey about policies around workplaces and talking about periods and menopause in the workplace. And in fact, a lot of women, most women, believe that there's such a thing as menopause leave, their employers will discriminate against them and they don't want their colleagues to know they're going through menopause. And, unfortunately, that really comes down to culturally we have a gendered ageism and menopause gets caught up in that.
Yeah, absolutely agree.
Very interesting. I'd like to change a little bit the sort of the direction of this. At HealthScreen, our emphasis is on preventative health and health screening. And I wanted to talk about ovarian cancer because there's currently no routine sort of screening test for ovarian cancer. I'm just looking at some of the statistics. So it's the sixth most common cancer in Australia, and obviously the survival depends on the stage it's picked up. So stage 1, the survival is greater than 90%. And the statistics are there are about 2,000 women diagnosed in Australia every year with ovarian cancer. So question, I guess, to start with for Alex and then Michaela, what can we do to improve the screening for ovarian cancer? What are the challenges?
Well, it's twofold. First of all, it's the statistics. Despite being the sixth most common, it's actually quite rare. And the second problem is that by the time symptoms develop, it's usually stage 3 or 4. You're usually asymptomatic at stage 1 or 2 because it doesn't produce any symptoms. And for that reason, because it's so rare, there are no reliable screening programs that are cost effective. It's all about cost effectiveness. And there are no reliable screening programs for it because it's so uncommon. So you would need to screen literally thousands of women with, I don't know, an MRI, a CT scan, or an ultrasound to actually pick one up. And then it's not quite clear whether picking it up earlier would actually improve survival. So the advice has always been, well, as far as I can remember, is that any symptoms that would prompt you to think about perhaps, having ovarian cancer, such as bloating, pelvic pain, those sort of things, should prompt an investigation, some sort of imaging at that point. So be it MRI, CT, or usually an ultrasound. The majority of stage 1 cancers that are picked up incidentally during a laparoscopy. So there is a cyst, it gets removed, and it comes back as very early ovarian cancer. But in practice, it's very difficult to advise. If there are symptoms, if there are changes that the woman notices, they should see a GP and get some sort of imaging done, is the bottom line.
Yeah. I have a question for Michaela, because the sort of patients I guess you would see is someone who comes and sees you, says, my mother had ovarian cancer, I have no symptoms. But, what do I do? Because I'm terrified about getting ovarian cancer. She was presenting at stage 4 and 5-year survival at stage 4 is, 10-15%. It's quite low. So, Michaela, how would you handle, what do you do in your practice?
I literally had this conversation with a young woman this morning. And it's a really tricky one, because if you go by the guidelines and by the book, you're right, there is no screening and they don't necessarily fit down any pathway. But this is where you have a really open and frank conversation with them. And you look at the age at which their mother was diagnosed. And as you said, the reality is by the time symptoms come, it's, we've nearly missed the boat. And we talk about, okay, well, and whether this is correct or not, but this is the way I tend to approach it. If a woman's really worried and concerned about it, I say, look, while Medicare may not fund X, Y, or Z investigation, it's certainly, if financially it's available to you, we can do regular, somewhat, every year or couple of years, ultrasounds. The reality is we may pick up things that are not cancerous that then mean we get caught on the medical merry-go-round of doing further investigations. But if you're happy to take on that risk for peace of mind, we can do it. Or if you think that will create further anxiety, let's look at then how frequently we do it. And it's a really, again, I keep saying this, but it's an individual approach depending on that person's background. And, it might be that there's not just ovarian cancer in the family. You ask further questioning, there's an auntie with breast cancer and a great aunt with something else, and that gives you more reason to do further investigation. But I think you do have to have that open and frank conversation with the woman sitting in front of you and say, well, there's no strict hard fast guideline. If this is what's going to give you peace of mind, as long as you're aware of what may follow on, it's an option for you.
Thank you. Sarah, I have a question for you. Your PhD is in genetics. When is it appropriate to do genetic testing? We're talking about BRCA and everything else. What are your thoughts on genetic testing in this context or other contexts?
I probably should defer to my clinical colleagues here, because I think the family history is probably the most important thing. But my PhD is in paediatric genetics and not familial cancer. So I might pass back to Michaela, if that's all right.
I actually and again, being in general practice land, this is something that usually we've involved genetic counsellors and a whole team of people. And it's actually, in the last couple of years, it's a really rapidly evolving space. It used to be actually really difficult to get genetic testing, and you could only access it through the hospital-based tertiary centre genetic clinics. You had to tick 10,000 boxes of family history and through specific types of cancers, and those people with the cancers needed to have a specific gene test before anyone in the family could get it. However, now you just do a quick browse online and pretty much anyone can order genetic testing online. It's usually still linked in with a genetic counsellor, but it's a very rapidly evolving space. So Sonia, did you have something to throw in the mix there?
I just worry about this area because I know a lot of consumers or patients do want to have general genetic tests, and there is a thing that you can send away, and it costs about $200 or $300 or $400, and you get a general genetic panel for being at risk of different illnesses and diseases, so to speak. I do worry about this. It's very difficult for health insurance purposes to then have to disclose, well, you've got this, that, or the other. I think this needs, again, expert guidance. Get to your good GP, look at your family history, look at the profile. I mean, one member with breast cancer is very different from having 4 or 5 or 7 members with breast and ovarian cancer. Get to the genetic counsellor. It is a very difficult and sometimes very confronting process, but I just urge people not to go out there, do their own research, organise their own genetic test based on saliva or whatever, and just, again, get to your good GP, have a good discussion. If it's beyond the GP's remit, hopefully they will refer off and get correct advice.
Yeah, and there is a group called Sorry, Michaela. There's a group called Inherited Cancers Australia that has a lot of very good resources. It's not for profit, but has a lot of very good resources exactly on all of these subjects.
Yeah. And also then just being aware that if you have, just to one last thing, even if it comes back as a negative result, so you don't carry the BRCA gene, that doesn't mean you can't get breast cancer. I think a lot of people get a false sense of security, but we know that's only a small percentage of cancer, so you still need to do your regular screening.
1 in 7 women over 50 will get breast cancer through bad genes, bad luck, dense breasts, whatever. We just need to be vigilant about cancer screening, particularly for breast, where we're very good at screening, and of course also for colon cancer, where we're very good at screening.
One of the points also I wanted to bring up is I totally agree with you, Sonia, in terms of sort of non-specific genetic screening. I think it's important that there's a pre-counselling before genetic screening, because the patient needs to understand what the implications of a positive test. And I think just sending it off to someone and it just comes back with some vague report is totally inappropriate, I think, as a medical practitioner. I feel
it's the same as doing an AMH for fertility. Women want that AMH for fertility, but if it's a low level, they might be devastated. So it's about doing the appropriate test, counselling appropriately, and knowing that you can deal with the consequences. So getting that good education out there first is imperative.
Yeah. Sarah, I have a question for you. In terms of, obviously Hales as an organisation, we talked about screening for cancers and sort of access to women's services. How do we improve access for under-screened group? We're talking about migrant groups, perhaps patients in rural areas, because medicine in the country town is a very, very different world compared to, to Melbourne or Sydney.
Yeah.
How can we improve that?
Well, I'm a small town country girl, so I know exactly what you mean. Look, I think for people in rural and regional areas, there can be real barriers around transport, but generally it's not as difficult as some of the challenges that are faced by our multicultural communities. A lot of those communities, they don't know about the screening programs. They're not aware that, how much they cost or where they go. There's a real lack of knowledge. Some communities, there's a sense of suspicion about, why is the government doing this? And then for others, they simply don't have access to Medicare. They don't have Medicare cards, and so the cost becomes prohibited. I think there's been a lot of really good work around, travelling breast screen buses, and you can do your cervical screening by a mail out kit, and our colorectal cancer screening through mail out kits. But the real challenge is raising awareness with our multicultural, multilingual communities that actually testing early means we can help, really trying to understand the barriers around cost and access, physical access. Bit of a waffling talk. Lots of barriers to access, David.
Yeah, it's a very challenging area. So, I mean, we're going to generate probably more questions than answers, hopefully some answers. I have a question now for Michaela and Sonia. The connection between hormones and mental health, and I know that Michaela does a lot of sort of mental health management as well. Can you tell us a little bit more about this? What's the connection, and how do we manage this?
Sonia, I think you will articulate the physiology behind it much better than I will articulate. But what I see on the ground is, sorry, I've thrown you under the bus there. But what I see on the ground is we know that there's a huge connection, and it's more than just that bandied around term, which I use somewhat hesitantly, of PMS, because we know there's a huge range, and there are a lot of women that are really sensitive, particularly to those progesterone changes. And that, again, something I see that comes in my door not infrequently is women say, there are chunks of time in my menstrual cycle where I genuinely feel out of control in terms of my emotions, my responses. I don't know who I am. I feel like I have an out of body experience. And we see that women throughout their cycle, but I see it amplified through perimenopause as well. That's actually one of the first things that women will come in and say. It's not the hot flushes, it's not the sleep changes, I just don't feel like myself. I don't know who I am emotionally. So we see that connection, and I think it's a really complex one, and it's really difficult to untangle. Sonia, did you want to add anything there?
Well, we know clearly that children, when they go through puberty, their mood will change. Their mothers will bring them in and say, this is a different person. PMS, so a cyclical change, changes with pregnancy. Some women just feel amazing through pregnancy. Their hormones are very different and very stable. Of course, postnatal depression, when their hormones change drastically again. Then we're faced with perimenopausal hormonal fluctuations, and then some women just dive bomb with their mood because their hormones have dive bombed at menopause. So we're facing a challenge throughout the spectrum, with only our steady hormones being prepubertal and postmenopausal. It's a bit of a challenge. Some women feel it more than others. 20% of women probably won't feel it at all. Some people don't even believe that PMS exists. And I think a lot of women would want to kill those people. So it's important to recognise, yes, there is a link. Yes, it will change throughout the lifespan. Again, get some good advice. The women do not want to be dismissed. I think a lot of the important thing that I do in a consult is just listen rather than try to talk, and then put people in the direction of some good information. Sometimes we need to check hormones. Some women will want to do that, and in perimenopause and menopause we don't need to do that. So again, there's lots of layers to this. but I am just firmly pushing everyone in the direction of some good information. And yes, there is a definite link.
Yeah, and in terms of what we do about it, again, that's hugely variable because for some women, that leveling out of hormones, whether that be with a contraceptive or, other devices, can be really helpful. But for other people, it can actually amplify their symptoms. So this is where we do need to, again, take that individual approach.
And try something, and if it doesn't work, you try 3 months or so, you try again. You just say, this is one approach, we're going to do this for now, and later on we may need to change it depending on your response.
Thank you. In the last 10 minutes, I wanted to talk about the future. And one of the, I guess, political questions I have is to the panel, do you think there's still a bit of a gender bias within the medical system?
Yes.
Can you expand on that, Sarah?
Well, I think we have decades and decades, if not centuries, of medical research done on men and treating women like small men. And we've had drugs removed from the market because they're specifically dangerous in women and not men. So our research still hasn't caught up with the differences, sex and gender specific differences between males and females, men and women. And then we hear so often from so many women that things like pain are dismissed when they get in front of clinicians. Now, that's not all clinicians, and I do think there are problems with communication style, but is there still gender bias? Yeah, absolutely there is.
I think we're getting better. I think that the government recently funded some really well needed hormonal treatments for women. So I just had a feeling of hope at that point and because menopause and endometriosis are such hot topics at the moment, I thought maybe we're starting to get it right and maybe we're getting in the right direction. So I just want to push it further and further in that right direction.
All right. In the last sort of 5 minutes or so, I'd like to go around the table and I would ask, each panel member, what myths about women's health would you like to disappear? Sarah.
Just that women are small men. We have specific factors, whether it's genetics, physiology, hormones, and then there are gender factors, caring expectations that limit women's ability to participate in stroke or heart rehab, for example, very well known. So I think we just have to stop treating males and females and women and men as if they're the same. We have no problem recognising that we need paediatric hospitals, that girls are not the same as women and boys are not the same as men. Well, we need to focus on the differences between males and females as well.
Very interesting. Michaela.
A really common one that I see, again, with the general practice lens, is that every symptom for women is stress or anxiety related, because it's something that I see far too often that women are dismissed for years, that it's anxiety and stress, when we know that anxiety and stress might be an element, but that's often driven by a physical cause as well.
I'm going to turn it round. The first thing is the myth that PMS doesn't exist for those people who really don't believe in it. I'd really like to have a good chat with them. Maybe another podcast, David, you never know. But the other thing is the major challenge for me at the moment is the hormone therapy challenges. I know that's not a myth, that's a certainty and a reality. Women are desperately trying to get patches, some tablets, etc. They're coming in and out, and it's been very difficult for practitioners, women, and also chemists. I would love that area to be sorted out. I'd love there to be more product available and, of course, more products on the PBS. But if those hormone therapy shortages could be sorted out, my life is a lot easier.
Yeah. And Alex, what myths would you like to disappear?
Mine is related to fertility. I think a lot of women and men feel that, there is no rush to have a baby. I mean, if worse comes to worse, we come to fertility clinic, we do one cycle, we get one egg, we get an embryo, we have a baby. I'd like for that to be gone, because it works very well, but it doesn't work for everyone. And as I said, the biggest thing for us is the biggest determinant of success is female age. If someone comes in the early 30s and they're relatively well, I can almost guarantee they'll have a baby. If someone comes in the early 40s, well, there is only very limited amount of things I can do to improve their situation. So I think general awareness of age-related decline in infertility is very important, and people must stop thinking that IVF will work every time.
I've run out of questions. I think it's been a very stimulating discussion, and I'd like to thank everyone. And hopefully, we can provide some evidence-based information to our viewers. If you want to see more information, please have a look at healthscreen.com.au and, of course, jeanhales.org.au for further information. I'd like to thank everyone for their time. Really appreciate this.
Thanks so much,
you.
David.
Thank
Pleasure.
you.